We are coming from a small university hospital, and our activity is mainly dedicated to outpatients. The system in Belgium is quite accessible with regard to health system for everyone. Rehabilitation, orthotics, and ITB, for instance, are quite fully reimbursed. But it's a little bit strange, but botulinum toxin, for instance, is only reimbursed in CP patient and in the upper limb post-stroke. So every patient has to pay when it's off-label indication, which is quite most of our patients. That's why we invest so much in neuro-orthopedic approach for our patients. So the team include myself as a coordinator, the guy who prepare everything, the rehab team, physical therapist, occupational therapist. I'm here with Thierry Deltombe, who is a neurosurgeon. We do neurotomy, ITB. We have 3 orthopedic surgeons, 2 for the lower limb, 1 for the upper limb, and I'm here with Delphine Wautier, which is with our lower limb orthopedic surgeon. We have 1 anesthesiologist who deal with everything for the ITB, refiling, management, quite interesting, and also a neurologist for dystonia and complex case. So our activity is mainly research activity, deal with diagnostic nerve block as an assessment tool for spastic patients based on a neurophysiologic study or to assess the predictive value before surgery. We also do research on selective neurotomy as a long-lasting effect, and Thierry Deltombe has almost 400 procedures until now. We try to compare neurotomy as a surgical approach as compared to botulinum toxin. I think we have to do a lot of research to compare treatment, because there is a lack in the literature about comparison study between one treatment according to another. So we are not able to promote guidelines as we don't have any research comparing treatment. It's a critical point, to my opinion. And so, scusi, Franco. So, and we have compared, for instance, neurotomy with regard to toxin, and we demonstrate that neurotomy is much effective than toxin to decrease spasticity. So, I will discuss this more in depth tomorrow. We published this month our guidance, which is quite different from guidelines. Guidelines are from the literature, level A, level B, level C. But as we don't have any study comparing treatment, we have to build guidance, which is expert consensus. And we publish our own monocentric guidance with dealing with equinovarus foot management. I will discuss with you today more in deep. So, spasticity patient flow organization is like this. The first consultation is with myself. We are mainly dedicated for outpatient coming from all over the south of Belgium. I do assessments using a largely video, nerve block toxin. I work with my rehab team for assessment, for functional electrical stimulation, evaluation, and so on. And I do perform follow-up when it's a medical treatment, simple. I think that our orthopedic surgeon has so many things to do, but not to see every spastic patient, of course. So once a month, one afternoon, we have an interdisciplinary spastic group consultation with the patient's candidates to surgery. And this is our last meeting previous month with a physical therapist, Thierry Deltombe, our orthopedic surgeon, and a big screen to see video during the consultation. So all members are present, and it can be fun times, very interactive. Each patient candidate for surgery are examined, and it took 20 minutes. It's quite fast, but time is an issue. We plan surgery, objective with patients, and we discuss with the patient and relatives. And each month we have 6 to 7 patients for candidate for surgery. We have a group consultation letter for the GP and the patient. He knows what he will benefit from. And the spasticity, we have a spasticity meeting summary for all the members. And this is the last meeting sheet with the member present. It was our 150 meeting session. We forgot to go to the restaurant. I see that Alberto goes it every 2 weeks. I'm very impressed. So I have to finance this for my team. And so this every patient with pathology complain what we did and what we plan, lengthened surgery, neurotomy, or ITB pump, or to ask to the team at Garch what we have to do with a very complex NHO problem today. So once surgery is planned, the patient is followed by the surgeon for neurotomy, 3-day length hospitalization, ITB, or the orthopedic surgeon for bone and tendon surgery. We perform frequent combined surgery, and I call it the dog and the cat in the operative room. You put a neurosurgeon and an orthopedic surgeon both together on the same patient the same day in the same room. It's quite, I'm a lucky man as a PMer. So systematic physical therapy and occupational therapist care and rehabilitation. Once patient is operated, he is followed by the surgeon as relative to cast, scare, and so on. And finally, the follow-up for rehabilitation process is by the rehab team and myself, with a systematic review of the feedback, the follow-up, during the monthly meeting by means of video. So every surgeon can see the functional result of the patient 2 months later, 6 months later, 1 month later, without visiting the patient, which is because time is an issue and time is money. So it's a problem, of course. So this is our spasticity flow, consultation with coordinators to perform assessments or medical treatment, follow-up by the rehab team. If the patient is complex or candidate for surgery, he benefits from an interdisciplinary consultations, surgery, follow-up by surgeon, followed by the rehab team, and feedback during the interdisciplinary consultation. This is the way we organize in order to perform the best work with the time dedicated to everyone. Thank you for your attention.